Hello, CyberMDs, and welcome to another lecture. Today we'll be covering syncope as it applies to the USMLE STEP 1 exam. In today's lecture, we'll cover topics such as reflex syncope, orthostatic syncope, arrhythmias, structural issues, and cerebrovascular etiologies of syncope. Please remember to subscribe and leave us some feedback so that we can continue to make these free medical education resources as useful as possible for you. Now, let's get started. Alright, so syncope is characterized as a transient loss of consciousness that is self-terminating. This loss of consciousness is primarily going to be due to decreased cerebral blood flow or a reduction in blood oxygenation. It's a sudden and temporary event that can occur in various circumstances, and understanding those nuances of the various etiologies is vital in your clinical practice. The most prevalent cause of syncope is a rapid drop in blood pressure. This abrupt decline can lead to a temporary decrease in blood flow to the brain, resulting in, again, a loss of consciousness. Now, it's important to note that while this is the most common cause of syncope, that syncope can arise from various other etiologies, which we will explore further later on in the lecture. But before we dive deeper into the causes and etiologies, it's essential to understand one other concept. That concept is presyncope. Presyncope refers to the symptoms that may precede a syncopal event. These symptoms can vary widely among individuals and may include dizziness, weakness, blurred vision, or nausea. Understanding and identifying presyncopal symptoms, as well as the events surrounding the event, can be crucial in diagnosing the underlying cause of the syncopal event. It can help to point towards a specific etiology or point away from a specific etiology. One of the key points to remember, and perhaps the most important takeaway from this entire lecture, is that syncope is a symptom. It's not a diagnosis. It's a manifestation of some underlying issue that needs to be identified and possibly even treated. Therefore, when you encounter a patient with syncope, your primary goal should be to find the etiology. This involves taking a detailed history, conducting a good physical exam, and ordering the diagnostic tests that you need based off of those initial findings. Now, let's provide a framework for you to understand those various etiologies of syncope. So remember, as we just mentioned, either the blood flow to the brain is reduced or the oxygen supply to the brain is insufficient. So the question becomes, how can that happen? It can occur if there's a lack of volume, maybe due to hemorrhage. It can occur due to inefficient pumping of the heart, such as in heart failure. Perhaps there is a physical obstruction to the blood flow within or outside of the heart, such as in a pulmonary embolism or maybe aortic stenosis. There can also be a sympathetic failure, resulting in an inability of the vasculature to maintain enough pressure to adequately perfuse the cerebral tissue. Keep these things in mind as you begin to see patients with syncopal episodes clinically. It will help you to frame your differential diagnosis as well as your workup. Now, let's discuss some of the common etiologies of syncope. First, we will dive into the topic of reflex syncope. Reflex syncope is a subtype of syncope that is neurally mediated, involving a reflex arc that's going to lead to vasodilation and or bradycardia. Let's explore the different types of reflex syncope and understand the mechanisms behind each. The first of these is vasovagal syncope, which is the most common type of reflex syncope and most common type of syncope overall, and it's often going to be triggered by emotional stress, pain, or standing for prolonged periods of time. The mechanism involves a sudden drop in that heart rate or a sudden drop in the blood pressure or both, leading to transient cerebral hypoperfusion. The central mechanism is the activation of the vagus nerve, vasovagal. The vagus nerve gets activated, which induces bradycardia and again vasodilation. These patients, as far as their presyncopal symptoms will go, they often will experience symptoms such as nausea, sweating, lightheadedness, and they will experience all of those right before they lose consciousness. This is the same type of syncope that occurs when some people see blood or when medical students pass out in the operating room on the first day of their surgery rotation. The management is mainly supportive, involving lying the patient down, elevating their legs to improve their cerebral perfusion. And this type of syncope is going to be both situation-based and can be reproduced in many cases, and that may help you to make the diagnosis. And you can also help make your diagnosis using a tilt table test in vasovagal syncope. Now, there's another type of reflex syncope called carotid sinus hypersensitivity. And that's going to be triggered by the stimulation of the carotid sinus, and it's often going to be seen in older individuals. The hypersensitivity of the carotid sinus baroreceptors is going to lead to that heightened response to the stimulus, causing a significant drop again in heart rate and blood pressure. It can be triggered by turning the head or wearing collars that are too tight or neckties that are too tight. And so it's often just managed through the avoidance of those triggering factors. There's also micturition syncope, which occurs during or immediately after urination. It's believed that the combination of vasodilation and, again, the bradycardia due to activation of the vagus nerve while peeing is going to be the actual mechanism behind this. So it's often going to occur at night or in the early morning hours, and patients are often advised to actually sit down to urinate to prevent that type of syncope. There's also defecation syncope, which is essentially the same thing, except when you're straining to have a bowel movement, you're performing the Valsalva maneuver, and that's going to stimulate your vagus nerve and cause you to have that drop in blood pressure and or that bradycardia, leading to a syncopal episode. So for defecation syncope, you're advising patients on proper bowel habits and sometimes even using stool softeners to avoid them from straining so hard and having that Valsalva maneuver. There's also cough syncope, which obviously is triggered by a bout of intense coughing, and again is believed to be caused by vagus nerve activation. A lot of times patients with cough syncope have a history of COPD or severe coughing spells. And for these patients, treating the underlying etiology of the cough is essential in managing their syncopal episodes. And then there's also swallow syncope, which is rather rare, but it is a type of syncope that occurs whenever a patient swallows, and again is believed to be induced by vagal nerve involvement and can be triggered by hot or cold food or drinks. And so identifying and avoiding those triggering factors, again, is going to be the primary management strategy in patients who have swallowing syncope. There's other situational syncopes that can occur, and you should be on the lookout for that as a part of your history, what was going on right beforehand. And so it's really important to remember that the vagus nerve goes to a lot of different places. As you can see on this list, we're talking about all these different types of syncope, and it's believed that the vagus nerve is involved in their mechanism of all of them. So it's going to go a lot of places. Those places include the brain, they include the vasculature, and they include a lot of your visceral organs. Therefore, there's a wide spectrum of situations and triggers that can cause the activation of the vagal nerve and subsequent syncope, again, due to the vasodilation and or the bradycardia that accompanies that activation. All right, next we'll discuss orthostatic syncope. And orthostatic syncope is defined as a significant decrease in the blood pressure when a person typically assumes an upright position, but we generally discuss this in the setting of any positional change. But it's typically going to be from lying or sitting down to standing up. And so the criteria for diagnosing orthostatic hypotension is going to include a decrease in the systolic blood pressure by a minimum of 20 millimeters of mercury, or a decrease in the diastolic blood pressure by a minimum of 10 millimeters per mercury with those positional changes. Orthostatic syncope can be immediate or delayed, each having its distinct characteristics and underlying mechanisms, and so let's dive into those two things. Immediate orthostatic syncope occurs within 10 seconds of a positional change, and it's going to resolve within another 10 to 20 seconds. This type of syncope is often due to, again, a rapid shift in blood volume, leading to that transient reduced cerebral hypoperfusion. The autonomic response may not be fast enough to compensate for that sudden change in position, and that's going to result in that hypoperfusion in the syncopal episode. And so things that can increase the risk for a faulty or delayed autonomic response can include increased age or diseases such as diabetes. And while it's generally less concerning in terms of immediate versus your delayed. It's essential to educate the patients on the proper way to change positions and to do that gradually so that they avoid these syncopal episodes. Now, in delayed or classical orthostatic syncope, that syncopal episode occurs within minutes, not seconds, of that positional change. The delayed response can be due to various factors, including dehydration, medications affecting blood pressure, or, again, autonomic nervous system disorders. The baroreceptor reflex might be impaired, and that can lead to inadequate cardiovascular compensation to that positional change. And this type of syncope is more concerning because there's a really large chance that this person has already gotten up from a seated position, they're standing, and now they're walking around, and then they're at a high risk for injury whenever they fall down after they have their syncopal episode or during their syncopal episode. And so it's going to necessitate a pretty thorough evaluation to identify the underlying etiology in patients who have this delayed or classic orthostatic syncope, because you really don't want them falling whenever they syncopize and then hitting their head, potentially having some sort of brain trauma or some sort of brain bleed that can be life-threatening. So other considerations for possible etiologies of orthostatic hypotension again include a lack of blood volume, which may occur due to diuretic use or hemorrhage and a trauma or dehydration. If there's not enough blood in the vasculature, there's not enough preload and/or cardiac output to adequately perfuse the brain. Therefore, a syncopal episode might occur. Now, other possibilities include sepsis, in which you have all these inflammatory cytokines out and about in your vasculature, and those are going to cause vasodilation and then a subsequent syncopal episode due to that decreased blood pressure. You may also see vasodilation and anaphylaxis, which can lead to syncope, but make sure you're looking for other signs of anaphylaxis, such as skin wheals and edema. And then lastly, in Addison's disease, the lack of cortisol and aldosterone may lead to profound dehydration and or hypotension, and that, again, can cause syncope. Now, let's talk about the clinical approach and the management of suspected orthostatic hypotension or orthostatic syncope. Whenever encountering a patient with these symptoms of orthostatic syncope, it's really vital to take orthostatic blood pressure measurements. So you're going to take their blood pressure when they're laying down, you're going to move them into a seated position, wait for a little bit, you're going to take their blood pressure again there, and then you might have them stand up and take their blood pressure again after they've stood up. And so measuring those blood pressures in different places or different positions is going to allow you to really get an idea as to whether or not orthostatic hypotension or orthostatic syncope is what's going on in that patient. So just remember that depending on the underlying cause, the management might include hydration, adjusting their medications if it's due to diuretic use or blood pressure medication use, and treating any other underlying medical conditions that could be contributing to the orthostatic hypotension. On this slide, I've just listed some of the other etiologies of syncope that you should keep in mind. Some of them we've discussed, some of them we haven't. Just remember that specific drugs and drug classes also have orthostatic hypotension as a potential side effect. And going into the details on these mechanisms, as well as the mechanisms of the other things listed on the slide, is going to be beyond the scope of this lecture, but you should review these things independently to prepare for your shelf and for your clinical practice. Now, another etiology of syncope is going to be arrhythmias. Various arrhythmias can precipitate syncope, and today we'll review the can't-miss arrhythmias or EKG findings that are pivotal in clinical practice. Arrhythmias cause syncope because they can cause inefficiency in blood flow from the heart. Therefore, you're always going to get an EKG on a patient who had a syncopal episode. Let's talk about some of those common EKG findings associated with syncope. Let's start first with AV block, a condition that's characterized by an impaired conduction between the atria and the ventricles. It's categorized into 3 degrees. First degree, where there's a prolonged PR interval greater than 200 milliseconds with no dropped beats. Second degree, which is going to be further divided into Mobitz type 1 or Wenckebach and Mobitz type 2. Remember that type 1 is a progressive lengthening of the PR interval with subsequent dropped beats, while type 2 has a regular PR interval that is lengthened greater than 200 milliseconds with dropped beats occurring. In third degree or complete heart block, there's no communication between the atria and the ventricles. Understanding those EKG findings for each different AV block is going to be vital whenever you're assessing these EKGs on these patients who have syncopal episodes. Then we can evaluate for HOCM. HOCM is another critical condition, and that's going to be characterized by asymmetric septal hypertrophy. And that's septal hypertrophy in the ventricles. EKG findings are often going to show deep, narrow Q waves, particularly in the inferior and lateral leads. And it's going to be essential to identify HOCM as it is a common cause of sudden cardiac death in young individuals. And this isn't an arrhythmia, but it still can lead to significant EKG findings. Next, we can assess our EKG for Wolff-Parkinson-White syndrome, or WPW. It's going to be identifiable through a delta wave on the EKG, which is this slurred upstroke of the QRS complex. And recognizing and finding WPW can save someone's life as well. Next on the list is going to be arrhythmogenic right ventricular cardiomyopathy, or ARVC. And ARVC is going to be characterized by the replacement of the right ventricular myocardium with this fibrofatty tissue. And the hallmark EKG finding is going to be the epsilon wave, which is a small positive deflection buried in the end of the QRS complex. So early diagnosis of that can prevent some pretty serious adverse outcomes. As we continue to work our way through the EKG, Brugada syndrome is going to be our next can't miss diagnosis. So Brugada syndrome is a genetic disorder, and that's going to manifest on the EKG as ST segment elevations in the right precordial leads, usually V1, V2, V3, and it's associated with a high risk of sudden cardiac death. So make sure you recognize that if it's on an EKG. Moving on, we have long QT syndrome, where the QT interval is prolonged, which predisposes individuals to go into torsades de pointes, and also this can lead to sudden cardiac death. And then we can assess for cardiac pause. A cardiac pause is just this temporary cessation of cardiac activity that's going to be seen on the EKG, and it's going to be a transient absence of QRS complexes. And that can be due to sinus pause, or AV blocks can cause this as well. And then lastly, you want to look for supraventricular tachycardia, or SVT, as another life-threatening arrhythmia that can cause syncope. SVT is going to be characterized by abrupt onset and termination of these rapid heart rates originating above the AV node. So it's essential to recognize and diagnose this on EKG because it can also, again, lead to cardiac death. Notice we're ruling out all of these life-threatening arrhythmias that can lead to sudden cardiac death. And so it's going to be characterized by a very narrow QRS, and it's typically going to be, again, less than 120 milliseconds, so very narrow QRS, and the rate of that is going to be greater than 100 beats per minute. And again, it has to have findings on EKG suggesting that it's originating above the AV node, supraventricular. And so keep all of these arrhythmias and EKG findings in mind as you assess the EKG that you order on your syncopal patients. Now, let's explore some of the common structural abnormalities that can cause syncope. The first of these is, again, hypertrophic obstructive cardiomyopathy, also known as HOCM. We just discussed this as a part of our EKG findings that we look for, and it's going to be characterized again by the abnormal thickening of the interventricular septum. That thickened septum is going to obstruct the outflow of blood from the left ventricle, and that's going to lead to a decreased cardiac output, decreased cerebral perfusion, and subsequent syncope. Especially, this is going to occur during exertion. And so patients may present with syncope, they may present with chest pain, and they may present with shortness of breath. And so the diagnosis is primarily going to be made through transthoracic echocardiography, or an ultrasound of the chest. So remember, we talked about we can see this on EKG, but the diagnosis is actually made using an ultrasound or an echo of the chest, of the heart itself. And so on that echo, we're going to see asymmetric septal hypertrophy, and the management can include lifestyle modifications, it can include beta blockers, and in a really severe case, it can include a septal myomectomy, where they actually physically remove some of this myocardium during a surgery. And so another structural issue that can cause syncope, moving on, is aortic stenosis. This is a narrowing of the aortic valve opening, restricting blood flow from the left ventricle into the aorta. Now, that restriction of blood flow, again, causes a decrease in cerebral perfusion, and that's going to have a subsequent syncopal episode following that decreased perfusion. Additionally, that narrowed valve is going to increase the workload on the heart, and so that can also lead to left ventricular hypertrophy and decreased cardiac output that way, which can also cause syncope. Remember the acronym SAD. Aortic stenosis makes you sad, so aortic stenosis can cause syncope, angina, chest pain, and dyspnea, shortness of breath. And so again, the diagnosis with this is also confirmed using a transthoracic echocardiography, which again is just an ultrasound of the heart. And so management can be medical or surgical depending on the severity of that stenosis, and that severity of that stenosis is going to be measured whenever they do all their measurements on that echo. Lastly, pulmonary embolism, or PE, and acute coronary syndrome, such as myocardial infarction, may cause alterations in the structure of the heart, short or long term, and that can be due to increased pressures and permanent damage to the myocardium, respectively. Each of these conditions can cause syncope and should stay in the back of your mind when considering a differential diagnosis. All right, so further considerations as far as etiologies go include cerebrovascular etiologies such as stroke or vertebrobasilar insufficiency. So look for things such as focal neurologic deficits on your physical exam and in your history to really rule out stroke, because it should stay on your differential until you can confidently rule that out. So it's also going to be important to make sure that the clinical picture fits if you're going to obtain imaging to rule it out. So patients who have stroke and then have a syncopal episode may present with dizziness or visual disturbances, weakness, ataxia, facial droop, slurred speech, those kinds of things. And again, the vertebrobasilar insufficiency is something to keep in mind as a possible etiology of syncope, and that's usually going to be pretty situational whenever they have some sort of exertion in their left arm, and that exertion using their left arm is going to cause that backwards flow in those vertebral arteries that's going to steal some of that cerebral perfusion and cause that syncopal episode. So when we are working up a patient who complains of syncope or passing out, what do? Well, first we make sure that the patient's not experiencing vertigo or dizziness, as this is often confused in the initial triage of the patient, and the history might be sort of unclear at first. So really make sure that this is syncope, that this isn't vertigo or dizziness or some other diagnosis. And once you are pretty sure that this is syncope, a true syncopal episode, then you can move forward and work on your differential diagnosis. So with regards to the pertinent HPI and taking a history in a patient who has had a syncopal episode, it's really imperative to gather information about the pre-event, the supposed syncopal event, as well as what happened immediately after that syncopal event, so post-event things. Additionally, a really thorough review of symptoms can help to solidify that syncope is the true issue at hand. So for pre-event, you should consider asking questions like, was the patient doing anything before the event? Were they standing, sitting? Were they lying down? Were there any warning signs such as dizziness, palpitations, or visual disturbances? How long did those pre-syncopal symptoms last, if they did have them? Were there any triggers such as a really stressful situation, dehydration, prolonged standing, the sight of blood? And then when you ask about the syncopal event itself, maybe consider asking if anybody witnessed the event who can provide additional information. How long did that unconsciousness last? Was there any involuntary movements that might suggest a seizure? Did the patient sustain any injuries during the fall that you also need to work up during their stay with you? Now, for the post-event history, you may ask if the patient oriented to, person, place, time, if they were oriented immediately after they regained consciousness. Were there any residual symptoms such as confusion, weakness, or headache? Has the patient experienced any similar events in the past? And so those are all post-event historical questions that you can ask your patient to gather some information. Now, a pertinent review of symptoms might include, but is not necessarily limited to, assessing for a history of heart diseases, of palpitations, of chest pain, evaluation for history of seizures or stroke or TIAs, transient ischemic attacks. You can inquire about any respiratory distress, assessment for GI symptoms that might indicate a vasovagal or reflex type syncope, maybe a micturition syncope or a defecation syncope. You may also explore any underlying psychiatric conditions that might be associated with syncope as well, and you can ask them about any drug use, whether it's prescribed or illicit drug use that could also cause syncope as well. For a physical exam, I'm not going to review everything on this slide. However, make sure you order the orthostatic vital signs or perform them yourself if you suspect orthostatic syncope as the etiology of the patient's syncopal event. Additionally, if you suspect that this is maybe vertigo or dizziness rather than syncope, I encourage you to learn about the HINTS exam and to check for any focal neurologic deficits to rule out any kind of stroke symptoms. Lastly, it's imperative that all patients with syncopal events receive an EKG and a transthoracic echo or an ultrasound of the heart, as you can rapidly rule out many life-threatening diagnoses with those two tests alone. If the EKG is normal at the time it's taken, a 24-hour Holter monitor may be used to record EKGs anytime the patient thinks that they are having an event or are about to have a syncopal event, and that way it can collect data on the patient's cardiac electrical activity at that time to rule out any arrhythmias as the etiology of the syncopal or pre-syncopal symptoms. All right, and I wanted to briefly run through a differential diagnosis of syncope. To assist in remembering a complete differential diagnosis, we can use the mnemonic "A Pisces woman had a PE," Pisces talking about your astrological signs. So let's break down each component of this mnemonic to explore the potential causes of syncope. So for the P in Pisces, we have pseudoseizure and pseudosyncope, and those are going to be non-epileptic events that can mimic seizures or mimic syncope, often associated with some sort of psychological distress. And you can take a detailed history, get witness accounts of what happened, and they'll have a normal EEG findings, or an EEG with normal findings, and that can help you differentiate that from true seizures. For the I in Pisces, that's to remind us of insulin and hypoglycemia, because low blood sugar can actually lead to an altered level of consciousness, which can mimic syncope. And those symptoms can include confusion and sweating, palpitations. So you take a blood glucose measurement to rule this out, and then if they are hypoglycemic, you can give them glucose. For the S in Pisces, that's going to be reminding us about sleep, which tells us that cataplexy, which is a sudden loss of muscle tone triggered by strong emotions usually, is also a syncope mimic. And patients may collapse, but typically they remain conscious throughout the entire thing, and that's going to be a diagnosis based off of a clinical history as well as sleep studies. The C in Pisces stands for cardiac arrest, which again is just the sudden cessation of cardiac activity, and that can cause loss of consciousness. And that's going to be made, diagnosis is going to be made with some sort of EKG and clinical assessment, maybe an ultrasound that shows you no cardiac movement or cardiac activity on that ultrasound of the heart. And so you're going to administer immediate CPR in these patients and perform ACLS as long as you're certified and practicing ACLS. And then the E in Pisces, it's a little bit of a cheat. I turned the E on its side to make like a fake M for metabolic. And so various metabolic disturbances can lead to syncope, such as Addison's disease. And so those clinical presentations of various metabolic disorders can vary widely based on the underlying issue, but you're going to order blood tests to assess for different metabolic functions and then address the underlying metabolic disturbance. The S in Pisces stands for seizures, so those sudden, uncontrolled electrical disturbances within the brain, which can present with convulsions or loss of consciousness, but typically they're going to have this post-ictal confusion, right? In syncope, we talked about this is a transient loss of consciousness, it's self-terminating, and the patient's usually oriented to person, place, and time, like right after they come back to. And so in a seizure, you're going to have this post-ictal state where they're confused. And so the diagnosis for seizure is going to be made on an EEG and clinical history, and you can manage them with antiepileptics. And now we move on to the woman PE portion of the mnemonic. And so the W in woman actually stands for vasovagal, can also remind us of vertigo as a mimic, and vascular to make sure that there's no hemorrhage and that there's no dehydration. So you can also I've seen people throw volume in under the two V's here for W. And so vasovagal, though, which is our most common cause, is going to be syncope that's triggered by activation of the vagal nerve, leading to hypotension and bradycardia. And so we talked a lot about that in depth, so I won't go too much into that. But for vascular, remember they can be dehydrated. For vertigo, remember they're going to be talking about how the room is spinning. And so those all have various managements and various ways of securing the diagnosis that you can look up outside of this lecture. For orthostatics, we talked about this a lot, and that's syncope occurring due to that sudden drop in blood pressure, typically when they go from lying down or sitting up to standing. And so that's going to be managed with hydration, slow positional changes, changes to medications, or other underlying things such as autonomic dysfunction. We talked about mechanical obstruction, so that's on our differential diagnosis. We talked a lot about arrhythmias. We didn't really talk about anemia, though. A profound anemia can actually cause a syncopal episode or pre-syncope clinical manifestations such as the lightheadedness or the dizziness that sometimes precedes a syncopal event. So anemia is actually a cause of syncope as well, and syncope mimic. And then we talked about cerebrovascular causes of syncope in this lecture. So we talked about vertebrobasilar insufficiency as well as stroke, but also trauma to the head can cause a syncopal event, as well as brain bleeds, so epidural hematomas, subdural hematomas, subarachnoid hemorrhage. Those sorts of things can also expand. Those hemorrhages can expand and cause us to have a syncopal episode. Then we have pulmonary embolism, which also reminds us about decreased O2 sats. So other things that cause decreased O2 sats can cause syncope, and pulmonary embolism can cause a syncope as well. And then the last E in PE is electrolytes. So severe electrolyte derangements can also cause syncopal events. So this is a pretty broad differential diagnosis that can help you keep some of these quote-unquote zebras in mind, while also focusing on some of the most common causes of syncope, such as our vasovagal and our orthostatics, and making sure that you're really giving a full workup to patients who present after a syncopal episode, and making sure you're not missing anything that could really hurt them or kill them in the long run. So in conclusion, the Pisces woman had a PE. It serves as a comprehensive tool to remember this very broad differential diagnosis. And for me, it works really well clinically. I hope this one helps you out as well. And so that's it. Thanks for tuning in. Thanks for bearing with us throughout this lecture. Please remember to like, comment, and or subscribe. Drop us some feedback. Let us know what we can do to improve. And thanks for tuning in again. Have a great day.